Hi, my name is Adam, and I'm going to be leading a lesson on HPA Axis Disorders and how they would pertain to the NBME shelf exam. There are three objectives for this lesson. First is to review the normal physiology of the HPA axis. Second is to go over Cushing syndrome, and third is to go over adrenal insufficiency, as those are the two main pathologies that are associated with the HPA axis. So first, let's talk about the normal HPA axis. So what does it stand for? Hypothalamic pituitary adrenal axis. So what it is your hypothalamus releases corticotropin releasing factor, which stimulates the pituitary to release ACTH, which then goes and acts upon the adrenal cortex to lead to production of cortisol. And as with many endocrine pathways, cortisol will negatively feedback on the pituitary and the hypothalamus to reduce the production of CRF and ACTH respectively, so that cortisol levels are held within normal physiologic ranges. And then when we take a deeper look at the adrenal cortex, we can see that it's actually a pretty complex endocrine organ that produces multiple substances. So moving from the outside of the cortex towards the inner portion of the cortex, the first zone is the zona glomerulosa, which produces aldosterone. Importantly, this zone is actually regulated by angiotensin II, not the ACTH produced by the pituitary, and this will become more important as we discuss some of the pathologies. But aldosterone's released, and its main function is to increase the amount of sodium and water that's reabsorbed in the collecting ducts of the kidneys, and it does so in exchange for potassium and protons, via ENaC channels. The second portion is the zona fasciculata, which releases cortisol. This portion is regulated by ACTH, and cortisol has many important physiologic functions. The ones that we'll most focus on, because they'll be most relevant when we discuss pathologies, include increasing our blood pressure, by two methods. First, by increasing the sensitivity of catecholamine receptors, and at high concentrations, binding to mineralocorticoid receptors and acting the same way as aldosterone. It also increases our glucose levels, both by increasing gluconeogenesis and by causing some insulin resistance. And it leads to decreased fibroblast activity, which can lead to poor wound healing and abdominal striae. The last portion is the zona reticularis, which produces our androgens. This portion is regulated by ACTH, and it's important for functions such as hair growth and muscular growth, particularly in women, because a greater proportion of their androgens are produced by the adrenal cortex, whereas in men, once they hit puberty, the vast majority of their androgens will be produced by the testes. And then just for completeness sake, if you go to the inner portion of the adrenal gland, there's the adrenal medulla, which is important for producing catecholamine stress hormones such as epinephrine, norepinephrine, but those have a completely different set of regulation. The first pathology that we're going to talk about is Cushing syndrome. So what is Cushing syndrome? Basically, it's when you have increased amounts of cortisol or other glucocorticoids, and it leads to a ramping up of the normal physiologic functions of cortisol, which leads to a characteristic pathologic presentation. So, we remember that cortisol is important for regulating blood pressure. So if you have too much cortisol, you can actually get hypertension, both because the catecholamine receptors are increasingly sensitive to the catecholamines, and because cortisol can act upon mineralocorticoid receptors at high concentrations. We also remember that cortisol leads to elevated glucose levels, both by increasing gluconeogenesis and by inducing some insulin resistance. So these patients will have hyperglycemia. In line with that, because they have this hyperglycemic state, you'll often see patients that will have weight gain. In addition, because we have this increased gluconeogenesis, and the basic idea is when you have increased cortisol, the body is trying to the body is stressed, and the body is trying to maintain glucose levels. So it'll do so by taking calories wherever it can, and one of the places it likes to hit is the muscle. So it'll break down muscle and lead to muscle weakness, and it also leads to some degenerative effects on the bones and can lead to osteoporosis. And this is important because in Cushing syndrome, patients often have a very characteristic appearance where they have a buffalo hump, they have moon faces, they have striae, and they often have a lot of abdominal adiposity and these thin extremities. And it's because the muscles are being broken down in order to create glucose in the blood, and then that glucose in the blood ends up becoming fat, in particular abdominal fat. So that's why they get the buffalo hump, the moon face, and then the striae is related to the decreased fibroblast activity that we talked about on the previous slide. And then lastly, particularly when we're talking about women who develop Cushing syndrome, we can see signs of hirsutism and virilization. And this is related to the fact that cortisol, or if you have cortisol, and this is related to the fact that sometimes when the cortisol producing areas of the adrenal cortex are ramped up, the androgen producing portion, the zona reticularis, will also be ramped up. So you'll see elevated androgens, and in women who most of their androgens are produced by the adrenal cortex, we can see signs of hirsutism, where they have hair in androgen-sensitive areas of the body, such as the upper lip, the chin, even portions of the chest and the trunk, and then in severe cases, virilization, which is hirsutism plus clitoromegaly, male pattern baldness, deepening of the voice, increased muscular build. So those are some things to look out for. And one important, for the purposes of the NBME exam, one way they like to really test this concept is by having you compare Cushing syndrome to a polycystic ovarian syndrome, or PCOS, because they have a lot of overlap. They both lead to signs of androgen excess in women. They both can lead to some hyperglycemia, and they both can also lead to amenorrhea, which isn't on this slide, but cortisol just can disrupt some of the normal physiologic functions, and in women can actually produce amenorrhea, or irregular or absent periods. So we're going to do some practice questions to kind of nail down the details that will help you pick out whether a patient has PCOS or Cushing syndrome in an NBME style question. So this is the first example. I'm going to give you all about a minute to read through this. Think about it. Think about whether you think this is a PCOS or a Cushing syndrome. Don't worry about the question at the bottom. Just try to, because with these NBME style questions, the first step is identifying what clinical disorder they're describing. And the second is just taking that second step and thinking and knowing some sort of detail about that presentation. But if you're not able to identify the presentation through the vignette, then you're kind of at a loss in terms of actually answering the question that they're posing. So for this exercise, for this question and the next one, I just want you to take a minute, think try to identify what presentation is being described in this vignette. So I'll give you all a minute. Okay, so that was 1 minute. So let's go through this question and try to identify the points that will point to PCOS versus Cushing. So for this, we see it's a 37-year-old woman. That doesn't tell us very much because PCOS and Cushing can be seen in the same demographic, these younger women. If it was somebody who was, say, 60, who was having all of these signs and symptoms, we'd probably be thinking more Cushing syndrome than PCOS, just because PCOS tends to affect women of reproductive age. The 37-year-old woman doesn't tell us much because we can see it in either sort of patient. She's been amenorrheic for 3 months. So again, that doesn't tell us very much because that can be seen in both conditions. And then we see increased facial hair growth, so some hirsutism, and multiple episodes of acne over the past year. So that again tells us there's increased androgens leading to hirsutism and increased acne. So again, it doesn't tell us a ton. And then we get to this point where it says that this patient has had 60 pounds of weight gain during the past 3 months. So this is kind of a point of deviation because often women with PCOS will have or will be heavy, or oftentimes will be obese. But when you're thinking of just the way that PCOS presents, it often doesn't present with weight gain. It's often a woman who's already heavy who then becomes amenorrheic. So the fact that this person has had 60 pounds of weight gain that corresponds exactly with when she's amenorrheic, at this point I'm starting to lean a little bit more towards Cushing syndrome. But let's read on. So she had this 60 pound of weight gain, and then we see she used to have regular menses, and then they became increasingly irregular. Her BMI is 36, and she was 210 pounds. So this tells me that prior to the 60 pounds of weight gain, she was actually 150 pounds, which for a woman who's 5'4" is pretty normal. So that tells me she wasn't actually heavy when this amenorrhea started, which again kind of makes me think that this is more so a Cushing's presentation. And then again, we get to a point that also points towards Cushing, which is her hypertension. So, women with PCOS, they're often heavier, and we know that increased weight is a key risk factor for the development of hypertension. But in a question stem, very rarely will they talk about hypertension in a woman with PCOS. That again is something that on the boards is more so associated with someone with Cushing syndrome. And then to further this point, not only does she have this significant weight gain, this hypertension, but then she now has truncal obesity with pink striae. And the pink striae, although in real life you'll see, a lot of people who have a lot of central adiposity will have pink striae whether or not they have Cushing syndrome. On an NBME exam, pink striae more than likely means that the patient has some sort of Cushing physiology. Not always, but if other portions of the presentation point towards that, such as the hypertension, the significant weight gain, you should really be thinking about Cushing syndrome. So nothing else really to go through in this question, but I guess just to highlight some things that'll be more for Cushing syndrome rather than PCOS. First is weight gain. Second, hypertension. And third, abdominal striae. So those are three aspects of the presentation that should make you think more towards Cushing's than PCOS. Now let's compare to the next question. So again, I'll give you about a minute to go through this and try to think if this is PCOS or Cushing. Great, so let's go through this question stem. So we see that it's a 17-year-old girl. So like I said on the last slide, when someone's in middle age, it's hard to tell whether they're PCOS or Cushing syndrome. Or I'm sorry, not middle age, but women of reproductive years. Whereas if someone is older, say like in their 50s or 60s, true middle age, then we're starting to think more of Cushing syndrome. But in someone like this who's young, like a teenager, we know some of the etiology of Cushing syndrome include like exogenous steroids, pituitary masses. Those are things that would be very atypical to appear in a young woman. So right when I see a 17-year-old girl, I'm already thinking this is more likely PCOS. But I like to look for other clues in the question stem. So reading through this, we see that she has increased urinary frequency over the past 6 months, so some polyuria. Her menses are irregular. And we see that she is heavy, but is not actively gaining weight. She's just a heavy woman. Then when we look, we see that there's hair growth over the upper lip and upper extremities, which is consistent with hirsutism, which again we can see in Cushing's and in PCOS, so it doesn't really tell us one way or the other. But then we see the patient has hyperpigmented, velvety, hyperkeratotic plaques on the neck, axillae, and groin, which is consistent with acanthosis nigricans, which is classically seen in someone who has a significant insulin resistance. And although when we talked about Cushing syndrome, we said one of the ways it leads to hyperglycemia is by inducing insulin resistance. In a question stem, if someone has very significant symptoms of insulin resistance, such as acanthosis nigricans or polyuria, which is pointing to kind of a diabetes or pre-diabetes picture, those are things that should make us think more so towards PCOS over Cushing syndrome. Whereas Cushing's will talk about hypertension, the patient will have abdominal striae, and the patient will have increased weight gain, not just being heavy, but actually actively gaining weight. In a patient with PCOS, their weight will be stable but heavy, and they'll often have signs of insulin resistance, significant insulin resistance. So acanthosis nigricans or polydipsia, polyuria, polyphagia. And I summarize these differences on the slide. So again, PCOS, someone who's overweight but not acutely gaining weight. Someone who has overt signs of insulin resistance. And then I didn't mention this, but there's actually multiple types of androgens that are produced in the ovary versus in the adrenal glands. And one important thing is that DHEA sulfate is produced specifically by the adrenal gland. So if you have someone with increased DHE sulfate, then you're dealing with someone with Cushing syndrome because the androgens are coming from the adrenal gland. Whereas if you see someone just with elevated DHEA and a normal DHEA sulfate, then you're dealing with PCOS because the androgens are coming from the ovaries, not from the adrenal gland. So then when we look at Cushing syndrome, we can see someone with recent or active weight gain. They'll have hypertension, striae. Sometimes they'll even give you they have like signs of osteoporosis, such as a fracture. And again, they'll have elevated DHEA sulfate because the androgens are coming from the adrenal gland. And then I just wanted to go through what you do when you think that somebody has Cushing syndrome based on the clinical presentation. So I really love this diagram from first aid. So based on this, we can see that there are 3 main ways you can diagnose somebody with Cushing syndrome. First, you can do an increased 24-hour urine-free cortisol. Second, you could do if they have an increased late-night salivary cortisol. And this is kind of a subtle but important point is that cortisol tends to be really low when you go to sleep. What cortisol, one of the things it helps do, it helps get some sugar in the blood. It helps so that if you have to do something active, you have some sugar actively in your blood and you're able to kind of get up and energize yourself. So when you're laying down to go to sleep, your cortisol is really low. It doesn't, just physiologically the way we adapt when we used to, live in caves or live in forests or whatnot. At night we go to sleep, we don't need that energy. We're just trying to rest. And then actually, as you're getting closer to waking up, your salivary cortisol starts to go up because your cortisol levels rise, cause a little bit of an intermittent hyperglycemia when you wake up, so that if you were to wake up and there's a bear in the cave, you're able to run away and you have energy to do so. So that's why it's a late night salivary cortisol. And then the third thing is inadequate suppression on a dexamethasone test. So if we gave dexamethasone, which is very similar to cortisol, we would expect it to negatively feedback on the pituitary and on the hypothalamus, leading to decreased ACTH levels. But in someone with Cushing syndrome, if you give them a low dose of dexamethasone, it actually isn't sufficient to negatively feedback, and the patient will still have elevated ACTH levels. So those are the three ways to formally diagnose Cushing's. And then the next most important step would be to measure the serum ACTH, because that can lead you down a pathway that will help you determine what's the etiology and how am I going to work it up. So if the serum ACTH is low, that tells you that you have a high level of cortisol or glucocorticoids independent of the adrenal glands. ACTH isn't present, independent of the normal function of the adrenal glands, I should say. So ACTH isn't stimulating the adrenal glands to produce cortisol or glucocorticoids, yet there's high levels of them. So there's two causes of this. One, the patient's taking exogenous steroids, which is, in clinical practice is the most common cause of Cushing syndrome. Or second, they have an adrenal tumor, which is just producing cortisol irrespective of whether ACTH is there or not. It's just working autonomously. So in a patient who has cortisol or who has Cushing syndrome with a low ACTH levels, we're thinking of exogenous steroids or an adrenal tumor. And if they don't have a clear history of taking systemic steroids, we would consider an adrenal CT to work that patient up. If, however, the patient has an elevated ACTH level, then we know that ACTH is being produced somewhere in the body, causing the adrenal glands to create too much cortisol, leading to Cushing syndrome. And in this sort of approach, there's two. We kind of think of two places where ACTH is coming from. It's either coming from the pituitary gland or coming from somewhere else in the body. And there's two main ways to determine that. One, we can do a high-dose dexamethasone suppression test. So like I said earlier, normally when you give a low dose of dexamethasone, it's not sufficient to negatively feedback on the pituitary and inhibit ACTH release. But actually in a patient with with Cushing disease where they have increased ACTH production due to a pituitary mass, a high dose of dexamethasone will actually lead to suppression of ACTH release. So if you give a patient high dose dexamethasone and you see that the ACTH levels drop, that should make you think that they have Cushing disease, where they have a pituitary tumor producing too much ACTH. And just a fun fact, for some of these endocrinopathies where there's too much production of a hormone or a stimulatory hormone, most of them cannot be suppressed. There's only two examples of these endocrinopathies that can be suppressed. One of them is Cushing disease, or an ACTH producing pituitary tumor that can be suppressed by high dose dexamethasone. And the second is a prolactinoma, which can be suppressed with dopamine agonists. So that's just a fun fact. So if we do a high-dose dexamethasone suppression test and we see that there's suppression, we know that the ACTH is coming from the pituitary gland. If it doesn't, then we know the ACTH is coming from somewhere else in the body. A common way for ACTH to be produced in the body would be in the setting of like a lung cancer, a small cell lung cancer. So if we see that a high-dose dexamethasone suppression test works, then we're thinking that it's a pituitary mass. Then we do an MRI of the pituitary. Whereas if it's not, then we know ACTH is coming from somewhere else in the body, probably small cell lung cancer. So we do a CT, chest, abdomen, and pelvis. The same logic applies to a CRH stimulation test. So if ACTH is just being autonomously produced by the pituitary, we wouldn't expect CRH, which normally stimulates the pituitary, to have much of an effect. But we actually see in patients with Cushing disease where they have a ACTH producing pituitary tumor, if you give them CRH, you'll actually see an increase in ACTH and cortisol. So if you see that, analogous to if you see suppression with high-dose dexamethasone, you would think that they have Cushing disease and you get an MRI of the pituitary. Whereas if CRH stimulation test doesn't do anything, then we know that's ectopically produced ACTH. And again, you do a CT of the chest, abdomen, and pelvis. This is a very high yield diagram and slide for your test. So I'd really make sure that you understand the components of this. kind of the flow, first measuring ACTH, and then doing some of these suppression or stimulation tests. And then I just wanted to point out, I remember seeing one of these NBME questions and being tricked by it. So the key thing here, so we'll read. So we see a 62-year-old man comes to the physician because of a 2-month history of increasing fatigue, weakness, malaise, and darkening of his skin. During this period, he has had a 20-pound weight loss, and he now has difficulty rising from a chair or climbing stairs. He has a significant smoking history, appears cachectic, has an elevated blood pressure. Exam shows hyperpigmentation of the skin and proximal muscle wasting. And we see that his serum glucose is elevated and he's hypokalemic. So this is just a very bizarre presentation because, when I see fatigue, weakness, malaise, darkening of the skin, those are things that I tend to associate with adrenal insufficiency, as we'll talk about next. And this weight loss also. But in this patient, we see that he's hypertensive and also has a hyperglycemia. So actually what they're trying to get at here is a patient with an ACTH producing tumor, or an ACTH producing lung mass to be specific. And things that pointed this out were the significant smoking history, which will always be present in someone with small cell lung cancer. And then the fact that although this patient has features of Cushing syndrome, such as the muscle weakness, hypertension, hyperglycemia, they also have this mixed picture where they have weight loss and darkening of the skin. And we'll talk about this next, how ACTH can lead to darkening of the skin. But this is just something I wanted to point out, that if you see someone, you think they have Cushing syndrome, they have darkening of the skin, and they have weight loss, that they may actually have an ACTH producing lung cancer causing Cushing syndrome. So next I just want to talk about adrenal insufficiency. So this is kind of the opposite. This is where we have low cortisol levels. And we divide this kind of into two camps. First, primary adrenal insufficiency, where there's a problem with the adrenal cortex. And then secondary or tertiary adrenal insufficiency, where there's a problem with the pituitary or the hypothalamus. So in someone with primary adrenal insufficiency, the problem's with the adrenal cortex. So they'll have low cortisol levels, but because of a lack of negative feedback, they'll actually have high ACTH. Some common causes of this: autoimmune, tuberculosis in the third world, and then some causes of acute hemorrhage, like someone with severe meningococcal sepsis or Sheehan syndrome in a patient who delivers a baby and has a lot of bleeding in that process. Symptoms of this, so we'll see kind of the opposite of Cushing's in some way. We'll see hypotension because they don't have cortisol sensitizing the catecholamine receptors or acting at mineralocorticoid receptors. We'll see weight loss. We'll also see in some interesting aspects of the presentation is they'll often have GI disturbances and sugar or salt cravings, which makes sense because of the lack of cortisol. They're losing, their sugars will be low, and because of the lack of aldosterone in this case, their salt levels will be low. So they'll get cravings for sugar and salt. So that brings us to kind of the most important portion when trying to think about whether someone has primary adrenal insufficiency versus a secondary tertiary adrenal insufficiency. And it's the fact that in a primary adrenal insufficiency, the entire adrenal gland is destroyed. So the patient will have low cortisol and low aldosterone level. So because they have this low aldosterone level, they'll have impaired sodium reabsorption in exchange for potassium and protons in the collecting duct, as we talked about earlier. And because of that, they'll have hyponatremia, hyperkalemia, metabolic acidosis, because they're losing sodium in their urine and they're not putting out, the potassium and the protons that they normally would in exchange for sodium. So this is very important, very high yield in terms of determining whether someone has primary versus a secondary or tertiary adrenal insufficiency. The second important point is, like I said, they have low cortisol, but they have an increased ACTH because the defect is in the adrenal cortex. So the pituitary hypothalamus are trying to tell the adrenal cortex, hey man, wake up. You got to produce cortisol for our body, but the adrenal cortex is just not responding. And because they have the ACTH levels that are elevated, they'll actually have hyperpigmentation, because ACTH is synthesized from a precursor POMC, and whenever POMC is produced, it produces ACTH and melanocyte stimulating hormone, and this MSH leads to hyperpigmentation. So, so that's two important things. In someone with primary adrenal insufficiency, where the entire adrenal gland is destroyed, they will have high ACTH levels leading to hyperpigmentation, and they'll have low aldosterone levels leading to hyponatremia, hyperkalemia, metabolic acidosis. And we compared it with a patient with secondary or tertiary adrenal insufficiency, where the problem is in the hypothalamus or the pituitary. They'll have low cortisol, but they have low cortisol because they have low ACTH. The adrenal glands are sitting there waiting to be stimulated, saying, "Hey man, where's my ACTH?" But nothing's coming because the pituitary gland or the hypothalamus isn't working well. So some causes of this include patient with chronic steroid use, because if you have chronic steroids, they're just going to negatively feedback the pituitary a ton and cause the pituitary to atrophy, or a pituitary mass where you're kind of pressing on the ACTH producing cells of the pituitary so that they can't function normally. These patients will have the same sort of symptoms as someone with primary adrenal insufficiency, but often less severe presentation. They might have mild fatigue, mild weakness, relatively normal BP. And again, they have low ACTH, which leads to this impaired production of cortisol. I'm sorry, I meant to make this point. So because they have low ACTH, they have low production of POMC, they have low production of MSH, and therefore they have no hyperpigmentation. So that's one key way to distinguish. The second key way is that if we remember back to one of our introductory slides, ACTH is responsible for the cortisol and androgen producing sections of the adrenal cortex, but not the aldosterone producing section of the adrenal cortex. So in these patients who have a low ACTH, they'll have impaired production of cortisol, but they'll actually have normal aldosterone levels, because again, aldosterone is regulated by angiotensin II. Because these patients have normal aldosterone levels, they'll also have normal potassium levels. They'll have normal acid-base status. They may still have a mild hyponatremia just because cortisol also can affect our salt balance. But in comparison to someone with primary adrenal insufficiency who will have significant hyponatremia, hyperkalemia, metabolic acidosis, someone with secondary tertiary adrenal insufficiency will have relatively normal potassium, acid-base levels, and sodium levels. And just to kind of go through another diagram of how you would go about diagnosing someone with adrenal insufficiency. So again, you do a morning cortisol, because as I talked about earlier, when we go to sleep, our cortisol is low. As we approach waking up, our cortisol levels slowly rise so that it gets some blood or some sugar in our blood. So if there's a bear in our cave, we're able to run away. So if the 8 a.m. cortisol is low, so less than 15, either 3 to 15, less than 3, the next thing you would do, you would try to stimulate the pituitary gland. So you do this cosentropin stimulation test. And if even after that you still have a low cortisol level, then you would get an ACTH to see, is the problem that my body is not producing ACTH, my pituitary hypothalamus isn't working to produce ACTH to stimulate the adrenal gland, or is my adrenal gland just not functioning and there's tons of ACTH but the adrenal gland can't respond? If there's tons of ACTH and the adrenal gland can't respond, then we get the primary adrenal insufficiency. If ACTH is low or normal, then we know the adrenal cortex is normal, but we have secondary, tertiary AI. And again, primary AI, the things that will make us think that it's this rather than secondary or tertiary adrenal insufficiency. 1, they'll be more symptomatic. 2, hyperpigmentation. Because of the increased ACTH leading to increased melanocyte stimulating hormone. And 3, they will have low aldo, leading to low sodium, high potassium, and acidosis. So here's a practice question. So, I'll give you 30 seconds because this is a shorter one, and I want you to think about what's the most likely diagnosis. Great, so let's go through this question. And I just want to preface it that, just like the NBME, I was trying to add a little bit of trickery to this. And we'll see that this actually isn't a presentation of adrenal insufficiency, but something that has a pretty similar presentation, especially on NBME exams. So you see it's a young patient, which doesn't tell us much because adrenal insufficiency, much of it is autoimmune, which we see in younger patients, who presents with abdominal pain, altered mental status. Two things we can also see in adrenal insufficiency. We see this patient has complained of fatigue and then increased thirst and increased urination, which is more bizarre. That's something I'm more so, polydipsia, polyuria, those are things I more associate with diabetes. So I'm like, oh, this is weird. This is a weird presentation for adrenal insufficiency. Then I see the patient has mild abdominal tenderness, which is normal. I see the labs, they have a mild hyponatremia, normal potassium levels, which I wouldn't expect with someone presenting with acute abdominal pain. I'm thinking more of a primary adrenal insufficiency, thinking that they would have hyperkalemia, a more significant hyponatremia. And then kind of the thing that gives it most away is the fact that this patient actually has an elevated glucose. So in adrenal insufficiency, we have low cortisol. Cortisol is important for increasing sugar in our blood. So we would expect someone with adrenal insufficiency to be hypoglycemic. So the fact that someone has hyperglycemia, even in the setting of these symptoms that sometimes could be associated with adrenal insufficiency, we actually realize that this is a presentation of DKA. So that's just one important thing to always think about in these questions, and to kind of just the same way we compare contrast PCOS with Cushing syndrome. In my mind, at least for the NBME style questions, I tend to compare contrast adrenal insufficiency with DKA because they both can present with kind of acute abdominal pain in a young patient who has this history of like fatigue, sometimes with weight loss. But the key giveaways are, if the glucose is elevated, you're not dealing with adrenal insufficiency, probably DKA, which normally the glucose in DKA is around 250 to 500. And then if you look at the electrolytes, if they have pretty normal electrolytes, you're probably dealing with DKA, not adrenal insufficiency. So this is our second question. I'll give you again 30 seconds. And this is kind of a two-part question. Great, so let's go through this one. So we see that we have a young woman. So again, we're thinking of some sort of autoimmune pathology normally when they give us a young woman who presents with abdominal pain, 2 weeks of fatigue. So this is similar to the past presentation. We also see this patient has increased salt cravings, which makes us think more about adrenal insufficiency where they're having salt wasting. And then the other giveaways are the patient has dark gingiva, darkening within the palmar crease. So the hyperpigmentation secondary to increased ACTH, trying to stimulate the adrenal gland, which is messed up. And then in the labs, we see hyponatremia, hyperkalemia, hypoglycemia. Those three things together should always make you think of an adrenal insufficiency picture. Hyponatremia, hyperkalemia, hypoglycemia. Hypoglycemia because they have low cortisol, hyponatremia and hyperkalemia because they have low aldosterone levels. So in this patient, we're thinking of a primary adrenal insufficiency because they have the hyperpigmentation, so we know they have high ACTH levels and the adrenal cortex isn't working. And also we see the hyperkalemia significant hyponatremia, telling us that aldosterone is low. So then in terms of acid-base status, so we know in the collecting duct, say this is the collecting duct, usually we pull sodium and water out, and we put potassium and protons in. So if this isn't working, then we know we're retaining potassium and protons, so we'll have an acidosis. And then the last practice question. So we can just go through this together just in the interest of time. So we see an older woman who presents with chronic fatigue. She has polymyalgia rheumatica and recently discontinued treatment. So the treatment for polymyalgia rheumatica, we would just know that that's a systemic steroid. So she's not using a systemic steroid. And patients who are on chronic steroids that just inhibit the pituitary a ton, lead to pituitary atrophy, we know that they have a secondary or tertiary AI, or adrenal insufficiency. So in these patients, we would expect cortisol to be low because they have low ACTH production. We would predict ACTH to be low because the pituitary is messed up. We would expect sodium to be normal to low because they have normal aldosterone levels. We would expect potassium to be pretty normal because they have normal aldosterone levels. And we would expect acid-base to be relatively normal because they have normal aldosterone levels. And again, they have normal aldosterone levels because the aldosterone-producing portion of the adrenal cortex is stimulated by angiotensin II and not ACTH. That's a key point. So lastly, I know this was a lot of information, very high yield though for the NBME exam. I just want to go through these questions just to check for understanding. So I'll give you all about a minute and then we'll go through them together, because if you understand these 3 key points, you'll be ready to kill your NBME exams. Great, so let's go through these questions just to wrap up this lesson and really hit on what are the high yield points. So what are the 3 tests for Cushing syndrome? So we know first, kind of the gold standard is increase 24-hour urine cortisol, which makes sense. They have elevated cortisol levels, so we'd expect urine cortisol to be elevated over a 24-hour period. Second, we could see that the patient has, if you give them a low-dose dexamethasone, it will not suppress ACTH. And that makes sense because it's kind of a key point that low dose won't suppress any patients with Cushing syndrome, whereas high dose will suppress patients with Cushing disease where they have an ACTH producing tumor. But low dose will not suppress ACTH in the setting of Cushing syndrome. And then third, if they have elevated late night cortisol, salivary cortisol. And again, just remember, when you're sleeping, you don't need a lot of sugar in your blood. Your cortisol will be low. As you start to wake up, sugar goes up in your blood, so you're ready to run away from the bear or the tiger or whatever we used to fight back in the pre-home days. So if the patient has elevated late-night salivary cortisol, we're thinking more so of a Cushing syndrome. Second question, which type of Cushing syndrome can be suppressed by high-dose dexamethasone, and what would be the next best step if this were the case? So we know this would be an ACTH producing pituitary mass. So the next best step would be a brain MRI. And then just my bonus question I threw in there, what is the other type of pituitary tumor that could be suppressed? So that would be a prolactinoma. That's just that's not a key objective from this, but just to see if people are paying attention and pat themselves on the back. And then the last question, what is the one clinical feature and one lab feature that will help distinguish primary adrenal insufficiency from secondary or tertiary adrenal insufficiency? So for the clinical feature, we know that in primary adrenal insufficiency, we have elevated ACTH, which leads to or is associated with elevated melanocyte stimulating hormone, which will lead to hyperpigmentation. And then for the lab feature, we also know that in primary adrenal insufficiency, they'll have low aldo because the entire adrenal gland's messed up. So then we know that they'll have a more significant hyponatremia, hyperkalemia, metabolic acidosis. And then just to answer this last question, when you stop systemic steroids, you'll develop a secondary or tertiary adrenal insufficiency because those systemic steroids over a long period of time led to atrophy of the pituitary gland, low ACTH production, secondary or tertiary adrenal insufficiency. So this slide has those answers. Thank you for your time and attention, and I hope you have a great rest of your day.